Good evening. Welcome to this peer review program on expanding hormonal therapeutic strategies in prostate cancer. A hearty welcome to the audience here in person, as well as to those joining us this evening online. I'm Dr. Matthew Smith from Massachusetts General Hospital Cancer Center. I have the great privilege of being joined today by two co-faculty, Dr. Tanya Dorff from City of Hope and Dr. Niraj Agarwal from University of Utah Huntsman Cancer Center. Thank you to PeerView and Zero for providing this session, and Bayer, Janssen, and Lilly for providing their educational grants for this symposia. If you haven't already done so, please complete the pre-event survey and look for additional follow-up polling during the presentation. We look for your active participation in this meeting, so please submit your questions, and we'll do our very best to answer them during the Q&A session. And to the extent possible, may do so in the middle of the session, various presentations. Please visit us at peerview.com, prostate SF23, to view the slides and practice aids now and down them after the event. Our goals today are to augment your knowledge of the rationale and clinical evidence for hormonal therapeutic approaches, equip you with the ability to employ optimal, individualized treatment plans that incorporate hormonal intensification strategies, and sharpen your skills to support the team-based management of adverse events associated with hormonal therapies. This is a very useful page for the clinicians in the audience. There's some valuable resources to our patients. We can only do so much in the context of an individual clinic visit to provide education to our patients. Here's a number of online resources that you may find valuable to share with your patients. They provide helps patients navigate issues surrounding the impact of certain AEs on their day-to-day life, as well as patients to actively participate in shared decision-making. I'd particularly like to call out Zero, a sponsor of this program. They offer comprehensive support for patients with prostate cancer. A lot of educational information available on that site, and many of my patients have found that most helpful. So our first presentation will be by Dr. Tanya Dorff. Dr. Dorff.
Thank you. Good evening, everyone. Thanks so much for being here after what have been, jam-packed long days here at GeoASCO. I've been asked to speak on how we're starting to incorporate some of the newer hormonal therapy approaches in the setting of localized disease, high-risk localized prostate cancer. So we know that about 15% of patients who present with localized disease will have some of the high-risk features that are outlined here that you're all familiar with, sort of the D'Amico risk stratification features. And I always like to tell my patient when I'm explaining to them how we use this stratification kind of more so than we use TNM staging almost at this phase of disease, that high risk doesn't mean high risk necessarily of death from prostate cancer, but just a high risk of needing more treatments to have a reasonable chance at cure than someone with a lower risk disease. So we can and need to use local therapy. I think there's some nihilism out there that a high-risk localized patient cannot be cured. I think they actually can, but we know from earlier studies of ADT alone versus ADT with radiation, for instance, that you're not going to cure anyone with ADT alone, and their survival is going to be better when we incorporate local therapy. So even if we can't cure them, by incorporating either surgery or radiation in this high-risk setting, we're definitely going to have them do better. But high risk does mean a high risk of some prostate cancer having already left the primary tumor, and that's where the role of systemic therapy becomes so very important. So as we have multiple different forms of radiation and surgery, has evolved as well. Our systemic therapies, which is what most of us in the audience perhaps are most interested in, have evolved, and we have more effective hormonal therapies. So the question becomes, how should we be incorporating them into practice for the high-risk localized state? And even more so, I would say we need to start looking at whether we can use some of our more sophisticated molecular tests to help us start to individualize treatment, selecting patients who need more or less intensification or de-intensification. Since we've had so many decades, I would say, of treating all the patients with exactly the same amount of treatment, it's really would be great if we could start doing differently. And I think you'll see in some of the ongoing studies that there is hope for that in the near future. So I'm going to show you a case just to have in the back of your mind as we go through some of the studies, and then we'll come back to it at the end. So this is a patient of mine who's 65 and presented with urinary retention and a PSA of 36. His biopsy showed Gleason 4+5 with extensive involvement. His CT and bone scan were negative. He did get a PSMA PET, and it was equivocal, as any of you who are doing PSMA PET scans in this setting will probably relate to. We often see things that we're not sure of, and so we have to make that decision about whether to give them the benefit of the doubt and treat them as localized in that context. But in addition to all that, with the PSMA PET, we're really thinking about what is this patient's life expectancy, what are his comorbidities, what is his urinary function, and how does that impact what types of treatments we may choose for him? The NCCN views either surgery or radiation as an option for high-risk localized prostate cancer, and we always try to tell our patients that they should be expected to have a similar rate of cure. However, you will note that someone with a short life expectancy might be considered for less aggressive therapy unless they are symptomatic, in which case some sort of local therapy might be palliative, even if not necessary to help them meet their life expectancy. But you can see that ADT is administered together with definitive radiation for anywhere from 1.5 to 3 years. You can do a brachytherapy boost. And then because of some more recent data, abiraterone is also an option for very high risk. Prostatectomy, on the other hand, there's no sort of definite ADT as there is with the radiation. However, if there's lymph node disease identified at surgery, then one can certainly consider ADT. And I would argue, based on SWOG 9921, other high-risk groups that are node negative should also be considered for adjuvant ADT, especially since, this is very heavily looking at radiation as an adjunct, but with radicals and raves, we're potentially not offering quite as much adjuvant radiation. So some of the newer data come from this STAMPEDE meta-analysis that was published by Gert Attard in Lancet last year. So STAMPEDE was this unique trial that included both metastatic and non-metastatic patients. Most of our others, like Latitude or Enzamet, were all metastatic. But because the abiraterone cohort, as well as the abiraterone plus enzalutamide cohort, allowed non-metastatic patients, those data were pooled to see what the benefits were specifically in that subset of patients. And what the results showed was significant improvements in metastasis-free and overall survival for those who received abiraterone with or without the enzalutamide. And so this opens the door for us to incorporate abiraterone in the treatment of high-risk localized prostate cancer patients. So here's the graphical representation, the Kaplan-Meier curves for metastasis-free survival. You can see a very strong hazard ratio, 0.53. And the overall survival as well from the meta-analysis, very strong signal, hazard ratio of 0.6. So this leads us to a current state where ADT is definitely included around radiation, but the incorporation of ADT pre or post prostatectomy remains a bit more of a gray area. And so we're going to look at a number of clinical trials that are ongoing that are hoped to help us better define. And then we have that whole question of radiation by itself or with ADT or not doing radiation until early salvage. But we know that neoadjuvant ADT can reduce positive surgical margin rate, so it's not standard, but it's not because there's not a possibility of benefit. And now with these newer hormonal drugs, we're going to see a lot of interest and rationale for trying to revisit the neoadjuvant approach with prostatectomy as well. So this is probably the trial that will be practice-changing if it's positive. This is Proteus, in which patients are receiving neoadjuvant ADT for 6 months, either alone, with placebo or with apalutamide. Then they go to prostatectomy, and then they continue for another 6 months, ADT plus apalutamide or placebo. The primary endpoints are pathologic CR. Now, that isn't a validated endpoint. It's more of a signal. So also, very importantly, they will be looking at metastasis-free survival. And Proteus was really designed based on a number of phase 2 trials showing that incorporation of the novel hormonal agents, such as abiraterone or apalutamide, or in some cases both, actually got us to a point where we saw some pathologic complete responses. So 10% with abiraterone, 10 and 13% in Raina McKay's trial. So it's taken a long time. Mary Ellen Taplin's study, which is the one at the top, was published almost a decade ago. But again, these form the basis for Proteus, which will be the more definitive practice-changing trial. Now, as we've heard at this meeting, prostate cancer is not one disease. There are various genomic underpinnings that can lead to different behavior and open the door to different therapeutic possibilities. So this GUNS trial is very ambitious, but this is really where many of us would like to see the field going. Let's try to treat prostate cancer as a different disease based on whether, for instance, there are these aggressive genomic changes, in which case that arm is going to be looking at the role of docetaxel. If there are more changes suggestive of hormonal sensitivity, looking at adding some of our next generation ADT agents. If there's MSI or CDK12, adding an immune checkpoint inhibitor. So this is all looking primarily at pathologic CR rate. This is signal finding. This won't be definitive or practice changing, but it's going to help us determine which approach in which genomic subgroup might be worth doing a larger definitive trial in. There's an unselected trial, so not looking at genomics, with the CDK4/6 inhibitor abemaciclib. So many of you may know that in breast cancer, there's synergy between hormonal agents and the CDK4/6 inhibitors. Some preliminary phase 1 data supported the concept and the safety, and so in this phase 2, high-risk patients will either get ADT, darolutamide, and abemaciclib, or ADT and darolutamide prior to prostatectomy. So this is such a great platform, right, for discovery to see what is happening in the tissue. PathCR is an early endpoint, a signal for go or no-go into larger definitive studies. So that was all based on DNA genomics. We also have RNA-based signatures that can help us prognosticate. Not every high-risk patient will have a terrible outcome, just like not every intermediate-risk patient will behave the same either. So the Decipher score is a 22-gene panel that created a signature that can help us differentiate within our clinical risk groups who is at higher or lower risk of prostate cancer progression. They initially validated this to answer the clinical question of whether all high-risk patients needed adjuvant radiation or whether some might be able to wait. So this was before radicals and raves. And what they saw is that if you had a high-risk genomic classifier score, you actually really benefited from adjuvant radiation, much more so than if your genomic classifier put you into a lower risk group. Again, these are all patients who have clinical high-risk features. And after many subsequent validation studies, Decipher was felt to be validated enough to be used prospectively in selecting patients for treatment. So this is the phase 3 ERADICATE study. Post-prostatectomy, if you have high-risk features leading to a CAPRA score of 3 or higher, you do a Decipher. If it's greater than 0.6, then you get into the study. If not, you're out. And then these high-risk patients are being randomized to an intensification strategy, ADT and placebo or ADT and darolutamide for 1 year, with a primary endpoint of metastasis-free survival. Unfortunately, we just learned that this study will be closed permanently due to poor accrual. I think there's still a lot of ambivalence about using adjuvant ADT in lymph node negative patients, even though, again, I think SWOG 9921 provides some rationale to do so. So unfortunately, we're not going to learn the answer to this trial, which I think could have been quite helpful. However, no reason to lose all hope. Decipher is still being used in a definitive radiation trial, NRG GU009. You can see this is a very large trial, and patients enter with high-risk disease features who are going to get definitive radiation. If their Decipher is high, they go into the intensification study of 2 years of ADT with radiation versus 2 years of ADT with apalutamide and radiation. Now, you might be concerned that abiraterone's not here, and we just showed you the STAMPEDE meta-analysis that says it's an option. So I think what's going to happen is certainly clinically lymph node positive patients probably aren't going to end up on this study, and it's those others or people for whom, for whatever reason, we don't necessarily want to use abiraterone who will enter into this arm. The low Decipher score patients go into the de-intensification of 1 year versus 2 years. And I'm really involved in this study and really interested in some of these other endpoints. Of course, we want to know that we're preserving cure, metastasis-free survival, but we're also going to see whether de-escalating allows men to suffer less in terms of cardiometabolic toxicity, how their quality of life is different, maybe testosterone recovery, after that very interesting session yesterday, and cognitive function. So, when people chose 2 years, they didn't do iterations of 12 months versus 24 versus 18 versus 36, right? So they chose 2 years, that beat 6 months, and now we're kind of filling in the gap in between. But using Decipher to really select patients in whom we feel we can do that safely. Another way to intensify would be to not use one of the novel hormonal agents, but to use something else that we think can be radiation sensitizing, such as a PARP inhibitor. So this is another very interesting study that's ongoing, in which patients receiving definitive radiation for high-risk prostate cancer who are getting 2 years of hormones will be randomized to niraparib or not, with a primary endpoint of disease-free survival at 2 years, but also looking at some later-term endpoints, including metastases. Radiation is complicated, right? There are some groups that do longer courses of hyperfractionated, and then some groups are looking more towards those hypofractionated regimens. And so the ASSURE trial was done using ultra-hypofractionation with intensification, sort of as proof of principle, you might say. In this study, they got abiraterone and apalutamide together with their hypofractionated radiation. And you can see that 98.4% achieved an undetectable PSA nadir. They did recover testosterone at least to non-castrate levels. This is not normal levels, on average at 6.5 months, which is reassuring. And they had, pretty robust biochemical recurrence-free survival. So an interesting phase 2 that allows us to consider intensified ADT even in the context of using hypofractionated radiation. ENZARAD is a study essentially looking at the role of enzalutamide intensification during radiation for high risk. And you can see they just really have to stratify for all the different variations that you get in radiation, whether there's a brachy boost, whether the pelvic lymph nodes are radiated. DAZZLE HiCap is a little more complicated study because it allows either definitive radiation or salvage radiation patients. It's a very big study. The primary endpoint is metastasis-free survival, despite the inclusion of these two kind of different groups, but they'll be stratified based on whether they're being treated in the definitive or adjuvant setting, salvage setting. And this is looking at 2 years of ADT with darolutamide versus placebo. Primary endpoint, metastasis-free survival. ATLAS is a study using apalutamide with a bicalutamide placebo or bicalutamide with an apalutamide placebo. So fairly complicated high-risk definitive radiation with this 2 months neoadjuvant, then concurrent during radiation, and then finishing out the full course. From this study, we did get a sneak peek sort of at what's happening out there and how are people doing radiation. You can see that overwhelmingly we're still doing more of a standard 6 to 8 week course, but 10% of patients are getting hypofractionated in the definitive setting and 6% are getting brachytherapy boost. So helpful for planning of additional trials. So let's go back to our case. Now that our heads are spinning with all the options for different systemic intensification and radiation strategies, he, remember, presented with urinary retention. So when I talk to patients about radiation versus surgery, one thing I'm saying is you'll have an equal chance at cure, but how will you be urinating? How will your quality of life be? And we kind of look at the two local therapy modalities in that context. In terms of comorbidities, if he had seizures or falls, I wouldn't want to put him on an AR antagonist. There are some other comorbidities like arrhythmias where I might not want to use abiraterone. Anticoagulants, you always have to check for drug-drug interactions. And then, making sure they have adequate social support to get through whatever treatment we propose. So this patient actually enrolled on NRG GU009. His Decipher score was high, so he got put into the intensification cohort. He was very nervous about getting the apalutamide, but fortunately for him, he was randomized to control. And so he got his biclutamide run-in, his LHRH agonist, and has completed radiation at this point and is doing well. So in conclusion, with radiation, we definitely use hormone therapy, and all these trials are looking at the role of intensifying, and some of them are looking at personalizing using genomic classifiers to potentially break out groups that can have less therapy in addition to all these intensification studies. Abiraterone is an option in the context of definitive radiation for very high-risk disease based on the STAMPEDE meta-analysis. But you saw all those other trials ongoing that will give us additional data and options. And the neoadjuvant trials related to prostatectomy, in particular Proteus, may end up changing the way we approach these patients. Right now, we usually take them straight to surgery, but in the future, it's possible we will end up incorporating systemic therapy perioperatively, so stay tuned. Whichever type of hormone therapy our patients get, we all know they struggle with a lot of side effects. So referring them to Zero can help them find resources for financial struggles, getting co-pays on these expensive medications, as well as sort of that emotional and peer support as they face however many months or years of these quality of life altering side effects that ADT does induce. So I recommend that you refer patients to this great opportunity for additional support. So with that, I will turn it over to you.
Thank you, Tanya, for a great presentation. And really liked your case. This is a common problem we face now, and I'm glad to see that your patient enrolled in a clinical trial. In the absence of a trial, or if you elected not to do a trial, what would your standard of care have been in such a patient?
So I am not using abiraterone across the board in my high-risk localized. I think you could make a case for it in someone who's got really bulky disease where you really want to know that you're killing more cancer, as we see from the neoadjuvant studies you do when you add the novel hormonal agent. So I think I would have talked to him about Abby, but I probably would have ended up just doing kind of a more conventional 2 years of ADT with the definitive radiation.
So you're, I'd say, equivocal on the STAMPEDE data. For this patient is very high risk, right? PSA 36, Gleason, I think 5+4 in all cores.
I would have spoken to him about it,
Yeah.
But given how nervous
Yeah.
he was about apalutamide, he probably would have ended up saying no.
Well
to
said.
abiraterone.
We have to meet our patients where they are. Niraj, do you agree? How would you have treated a similar patient in your practice?
So we do occasionally use abiraterone for locally advanced or high-risk prostate cancer following the STAMPEDE criteria. So this patient is close to 40 nanogram per mil of PSA, 36, has a Gleason score which is high, and then it looks high risk overall. So I would probably offer abiraterone. At least we'll bring this in the discussion.
Yeah, so Tanya, I have a little bit of a provocative question for you to end this session, but in that same a similar patient, if the PSMA PET were not equivocal, but showed clear, let's call it, small burden of metastatic disease, what would you have recommended in that case?
So in that case, absolutely. They're metastatic. If you really believe the PET scan is positive, then he's metastatic and low volume. I do treat with abiraterone treatment to the prostate primary, like radiation. Yeah. And I probably would do metastasis-directed therapy, which is not evidence-based, but something I think a lot of us are doing in the low-volume setting. We just try to maximally treat the disease we see to try to get patients into a good deep remission. Yeah,
and I asked that question. We would manage a patient like that in a very much similar way, and I think it speaks to the convergence of treatment, right? So if he was very high risk or regional risk, he gets prostate radiation, nodal radiation, ADT, and probably a second drug, right? So if it's low volume metastatic disease, he gets almost the same treatment. Maybe you don't radiate the nodes, and perhaps you radiate the metastases. So it's a remarkable convergence of treatment, and I think it speaks to the value of PSMA PET to help kind of distinguish where the patient is in their disease state and to optimize treatment decisions.
Yeah, but also exposes sort of the gaps. The PSMA PET has kind of outpaced how the data can keep up with how to manage them, so it does pose some challenges. But I mean, essentially, we will better define who actually is metastatic versus who is localized. Yeah.
Niraj, you get the last word.
Yeah, I have a feeling like if you look at the STAMPEDE trial patients, and if PSMA PET was available when the trial was being conducted, and if you had done the PSMA PET, I bet many of them would have low volume metastatic disease on the PSMA PET.
Yeah, it's an excellent point, and we of course know this to be true in a similar or analogous situation, non-metastatic CRPC by conventional imaging. If you look at that patient population with PSMA PET or similar patient population, nearly all of them have detectable metastatic disease. So thank you for that great discussion, and move on to the next section. So this is my case, patient with de novo MHSPC, 57-year-old man with screening PSA of 37. This was a real case. It's not meant to contradict Dr. Dorff's presentation. Prostate biopsy showed Gleason 5+4 and 4+5. MRI reported confluent PIREDS 5 lesion throughout the peripheral zone extending to the apex of the base, and a probable metastasis to the right iliac bone. Technetium bone scan reported uptake at that same location, and he had a PSMA PET that showed these two lesions, so the right iliac metastasis, another metastasis in his cervical spine, and additional metastases in multiple ribs, which are not shown on these images. So think about that case as I walk through the management of metastatic hormone-sensitive prostate cancer. Historically, this group of patients have poor clinical outcomes with short interval to disease progression and short overall survival. Survival is related to the type of presentation, de novo versus recurrent, location of metastases, and extent of metastatic disease. We have clear level 1 evidence that intensification of systemic treatment improves overall survival. Disappointingly, though, despite that consistent and compelling level 1 evidence, the adoption of treatment intensification in the United States has been poor, and most patients continue to receive ADT alone for metastatic prostate cancer. This is data from the STAMPEDE trial, control group, making the point that patients treated with ADT alone have a poor clinical outcome. These are about 1,000 patients enrolled between 2005 and 2014, treated with ADT alone. Event-free survival, failure-free survival was about a year, and overall survival is only about 42 months. The event-free proportion is related to sites of metastases. The same is true of overall survival, with patients with soft tissue metastases, typically lymph nodes, doing the best, bone only doing worse, and those with both bone and soft tissue doing the worst. this is making, again, the case that the sort of predictors of overall survival, in this case by presentation and extent of metastatic disease. This is the controlled group from charted in Getug 15. Patients with de novo high volume metastatic disease have an overall survival of about 3 years with ADT alone. De novo low volume, 4.5 years. Recurrent high volume, about the same. And patients with recurrent low volume disease have an overall survival of about 8 years. And then US hospital registry data tells us that about more than half of patients with low volume HSPC are recurrent metastatic disease, and only about 15% of patients relapse with high volume disease after surgery or radiation therapy. That probably speaks some to the biology, as well as the fact that we can monitor these patients with PSA and typically intervene with re-staging early. This is a fairly remarkable set of data summarized on this slide. All but one of these studies showed an overall survival benefit in metastatic hormone-sensitive prostate cancer. And collectively involved nearly 10,000 patients in these trials. So really remarkable set of data and has dramatically moved the field. We now have to see that this evidence is adopted in clinical practice. The first studies to look at intensification moved docetaxel into the MHSPC setting. 2 of the 3 trials reported overall survival benefit, although subsequent analyses have shown that it appears that that benefit in overall survival is limited to the so-called high-volume subgroup of patients. A series of trials then looked at AR pathway inhibitors and showed consistent overall survival benefits in favor of intensification. That is true of abiraterone, enzalutamide, and apalutamide in combination with ADT compared to ADT alone. In contrast to the docetaxel experience, the survival benefits in the case of AR pathway inhibitors appears to be similar across a spectrum of prognostic groups, including high versus low volume disease. And then what I'll talk some more about tonight will be these more recent trials that have looked at so-called triplet therapy, looking at, in the case of Arisen's, ADT, docetaxel, and darolutamide compared to ADT and docetaxel alone, and piece 1 looking at the triplet of abiraterone, ADT, and docetaxel. I'd also be remiss for pointing out that we can improve survival not just with drugs, but with radiation therapy. Stampede Arm H showed that prostate radiation appears to improve overall survival in patients, at least in the low volume subgroup of that study. So it's something to consider, and we sort of covered that a little bit in the hypothetical case that we reviewed earlier. The adoption of intensification, regrettably, in the United States has been poor. A population-based study report, for example, from 2014 to 2019 reported that only 12.7% of patients had received intensified systemic treatment. That's been validated in other experiences. And so we clearly have a lot of way to go. I would say the target is not 100% of patients receiving intensification, because there are patients who appropriately may receive ADT alone. Those would be particularly older, frailer patients with significant medical comorbidities, as well as patients who have particularly good prognosis disease, for example, low volume nodal disease that recurs many years after primary treatment. So the survival benefit with, in this case, abiraterone acetate is compelling. This is long-term follow-up data from the Latitude study and the Stampede arm, looking at the addition of abiraterone acetate to standard of care, showing this clear, compelling improvement in overall survival with a hazard ratio of 0.66 and 0.60, respectively. This is a big treatment effect. Similar magnitude of benefit was seen with other AR pathway inhibitors. Shown here are results of the Titan study of apalutamide, Arch's trial of enzalutamide, and the Enzamet study also looking at enzalutamide. There are a number of factors that should contribute to treatment decisions. While a lot of focus has been paid to this issue of disease classification by de novo versus recurrent, high volume versus low volume, or in the case of the Latitude trial, high risk versus low risk, we also have to consider the patient in front of us. as an important part of decision-making, not only their wishes, which are critically important, but also their age, life expectancy, comorbidities, concomitant medications. Those are going to have significant roles in deciding whether intensification is appropriate, and further, what agents might be preferable should intensification be considered. There are a number of disease characteristics that I alluded to, and those things really need to be considered carefully in making decisions, but it's not just as simple as classifying prognosis by volume or risk or de novo versus recurrent. In ARASENS, we looked at the triplet of ADT, docetaxel, and darolutamide. It's important to note the history of this study because at the time the study was designed, shortly after there was confirmation that docetaxel improved overall survival in MHSPC when added to ADT. So we elected to take the winning arm of the previous trial and make that the control arm of our study. So we took that bold approach. And we also felt that given that overall survival had been demonstrated with docetaxel to really make a difference, we should use a primary endpoint of overall survival. So that was the approach. Eligible patients were randomized to ADT and docetaxel for 6 cycles plus darolutamide or placebo. The primary study endpoint was overall survival with a number of key secondary endpoints, including time to castration-resistant disease, time to subsequent anti-cancer therapy, event-free survival, and time to SSE. So here's the primary analyses that were published last year and led to FDA approval of darolutamide in this setting. Compared to placebo, darolutamide significantly improved overall survival. The median survival in the placebo group was 48.9 months, very similar to the historical experience with ADT and docetaxel, not yet reached in the triplet arm. The hazard ratio is 0.68, and that, as you can see from the p-value, is highly statistically significant. We stratified patients in that study by de novo versus recurrent metastatic disease, and in pre-specified and planned subgroup analyses, there were similar benefits in the poor prognosis de novo disease as well as in patients with recurrent metastatic disease with very comparable hazard ratios of 0.71 and 0.61 respectively. I should say that there was consistent benefits across all of the other pre-specified subgroups as well. At the time we reported that data, there was a lot of interest by the community in how the results would be by other subgroup analyses. So kind of based on group interest, we looked at a number of exploratory subgroup analyses, and Dr. Maha Hussein presented this data yesterday. So we did high volume versus low volume and high risk versus low risk. And as you hopefully can see in this very data-dense slide, that there's consistent benefit really across all of these subgroups, sort of confirming the observations that were previously reported. And I would say not at all surprising because the magnitude of the benefit was large in the intention to treat population, and there's a lot of overlap in these risk classification schemes for high risk or worse prognosis disease. Darolutamide also showed benefit in a number of key secondary endpoints, including time to CRPC and time to pain progression. PEACE 1 is another study that provides important information about so-called triplet therapy. PEACE 1 is a bit more difficult to explain. It had 1-to-1 randomization between standard of care plus ABI, standard of care plus prostate radiation, or standard of care plus prostate radiation and abiraterone acetate. Further, the standard of care changed during the conduct of the study. Initially, it was ADT with docetaxel at the discretion of the treating physician. About midway through the study, that was changed to require docetaxel. And then the triplet therapy, ADT, docetaxel, and abiraterone, was a subgroup analysis of the patients who received docetaxel as part of standard of care. This is the docetaxel subgroup in the trial, showing an improvement in overall survival. This is sorry, this is radiographic progression-free survival. Hopefully, here we go. Overall survival here, that's the primary endpoint of the trial, showing a hazard ratio of 0.82 in the overall population. Compare that to 0.68 with Aerosens. And then in the docetaxel population, which is more comparable to Aerosens, the hazard ratio is 0.75, showing that benefit. So now back to our case. This is, again, 57-year-old man with screening PSA 37, extensive localized disease, confluent pyrids, 5 lesions in his prostate, bone scan with a solitary bone metastasis, but PSMA PET showing additional sites of disease. So, Dr. Agarwal, what do you think? How would you manage a patient like that?
So patient has metastatic disease on the PSMA PET. Although we do not know if any of those trials, so I'll come to the point. We don't have the evidence from the bone scan, or bone scan did show, right?
Bone scan and MRI showed a showed a single metastasis. That's the one that in the pelvis.
Yes.
And PSMA PET revealed additional sites of disease.
So this is a very commonly emerging situation in the clinic. Do I call it high volume disease or do I call it low volume disease? So I tend to look at the accrual criteria for those multiple trials you have shown just now, and I will call it a low volume disease based on conventional scan, and I'll treat this patient as a low volume metastatic hormone sensitive prostate cancer.
And can you clarify what that would mean in your practice?
Yeah. So low volume patients, if they have intact prostate, they are considered for prostate radiation, and they are also considered, obviously we use a novel hormonal therapy like abiraterone, apalutamide, or enzalutamide, and if they have less than 5 sites of metastasis in the bones, we also consider oligometastatic radiation therapy. So in this case, patient will be a candidate for receiving radiation therapy to the prostate, radiation therapy to the one site on right iliac bone, and starting ADT with one of the novel hormonal therapies.
Very good. And do you have a preference among the agents?
It is mostly driven by the affordability, cost, copay, and drug interactions. So we first rule those out.
Are there differences in the effectiveness between those agents in your best judgment, recognizing we don't have large randomized controlled trials to ask that question?
No.
Okay.
Yeah.
Dr. Dorff, what do you think?
So if I'm being honest, I would treat this patient as high volume because of the PET findings. If I look at it and it really looks, there is already one definite bone met on conventional imaging, but there are many others that are probably real. So if I really felt they were real, I would offer, and he's also 57, I'm going to offer intensified systemic therapy. I'm going to talk about triplet, see if he's willing to do chemotherapy. I would be okay with doublet because, the role of the docetaxel has not actually been measurably proven because of the designs, as you elucidated, for the triplet trials. And we do have ongoing triplet trials, like we have an institutional metastatic hormone sensitive trial with ADT, ABI, and talazoparib. So, I'm always looking at clinical trials as a valid option. I would consider treating his primary if he gets into a very good remission. For instance, I would consider, if he doesn't go on my PARP triplet trial, and let's say we give ADT docetaxel and abiraterone, for instance, I would consider putting him on like SWOG S1802, where there's a randomization of cytoreductive prostatectomy or not, or definitive radiation of the prostate or not.
See, there is a difference of opinion among 2 high-volume prostate cancer oncologists right here. So this is a challenging situation. And I think as the time goes, by next year or next 2 years, we will be increasingly relying on, hopefully, biomarkers. If this patient has P53, P10 loss, RB loss, at least 2 of them, I will be more swayed towards using chemotherapy in my real practice. So I'm bringing in more nuances to our discussion.
And I chose this case deliberately because I recognize there are a lot of controversial aspects to this. This is not an unusual case, though, I would add. We're seeing these kind of patients on a regular basis. This particular case has all the attributes that make it particularly, let's say, controversial. We have a long way to go in optimal management of this disease, but I'd also say we've come a long way, right? Because if we had this same conference 10 years ago, there would be consensus to treat the patient with ADT alone.
Continuous. People will be talking about continuous versus intermittent in those days.
So we have come a long way. So there's agreement on the principle here that we're going to intensify therapy with at least ADT and an AR pathway inhibitor, maybe docetaxel. Not everyone would agree on that point. And likely treat the primary, particularly in a young patient with high volume disease. I think that was roughly the consensus between the two of you, and that's actually, we gave this patient triplet therapy and treated as primary, and the pelvic bone met, just because, while you're there, you might as well go after that. But radiating his cervical spine metastases and ribs gets to be a little bit more morbid. You could argue whether it was required to treat the pelvic bone metastases. I wouldn't disagree with Dr. Agarwal for going after the other metastases, but we do have a lot to learn in the role of metastasis-directed therapy. But there's a lot of principles in this case I think we can take away from, and hopefully we're helpful to the audience. So with that, we'll now ask Dr. Agarwal to present his.
Sounds great. So it's already getting exciting. More exciting with that case. So I'll be talking about PARP inhibitors, and so emerging therapies, PARP inhibitors in combination approaches, and how they are being applied to earlier disease situations, so hormone-sensitive setting. And I'll also touch base on cell cycle pathway disruption, or CDK4/6 inhibition, as an emerging potential therapeutic option in our patients with metastatic prostate cancer. So first of all, who should we test? And I often find it difficult to completely obtain a very extensive family history in a prostate cancer patient. And especially when we are really relying on the memory of a patient who's already exhausted after driving 3 hours to reach to the cancer center, or sometimes they are driving even more, or they are feeling exhausted, burdened with the diagnosis of prostate cancer. So these criteria are there. We have to technically follow them, but I have made it easier in my clinic. All patients with metastatic prostate cancer, pretty much all guidelines tell us that patients with metastatic prostate cancer should have germline and somatic tumor testing. So I do that for all patients. And if I look at high risk, very high risk, regional, and so many other categories, and if I'm not able to rely on, say, family history of prostate cancer, I go ahead and get the germline testing done. If germline testing is positive, then patient see a genetic counselor. So it used to be opposite. Patient used to see genetic counselor first, and then germline testing used to be sent, and we were losing 30 to 40% patients who were not actually seeing genetic counselors. So we reversed that, and we are now sending genetic testing or germline testing from the clinic, and then if they are positive, they see a genetic counselor. And regarding somatic tumor testing, its decision-making is easier. We sent the patient's tumor for comprehensive genomic profiling, so that I don't have to worry about obtaining each one of those mutations on a piecemeal basis. It is often cheaper for patients to get, say, Foundation Medicine testing or Tempus or Caris testing. There are so many testing companies which are offering pretty much high level of deep enough tissue testing that I find them very acceptable. So every single patient with metastatic prostate cancer undergo some kind of comprehensive genomic profiling of the tumor. So take-home message, all patients with metastatic prostate cancer should undergo comprehensive genomic profiling and germline testing. And then if they are positive, genetic counseling is recommended. So let's go to the Amplitude trial. This is one of the ongoing trials where patients with newly diagnosed metastatic castration-sensitive prostate cancer who harbor germline or somatic homologous recombination repair gene alterations. These patients are being randomized to abiraterone acetate plus ADT. So androgen deprivation therapy and abiraterone acetate are the backbone, and then niraparib is being added to the experimental arm. And please note that niraparib dose is 200 milligram as opposed to 300 milligram daily because of the interaction with abiraterone, or because of the toxicity profile of niraparib and abiraterone. So this is a dose which was chosen in the later trial, which was magnitude trial, which I will be talking about in a moment. So based on those results, niraparib dose is 200 milligram in this trial. So the primary endpoint of this trial is investigator-assessed radiographic progression-free survival, and secondary endpoints, key secondary endpoints are overall survival, symptomatic progression-free survival, and time to subsequent therapy. And this is a relatively large trial. 788 patients will be enrolled. This is TALAPRO-3 trial. In this trial, a very similar strategy. Patients who have newly diagnosed metastatic castration-sensitive prostate cancer, they are being randomized to enzalutamide and androgen deprivation therapy versus androgen deprivation therapy plus enzalutamide plus talazoparib. And talazoparib dose is 0.5 milligram in this trial based on the pharmacokinetic studies, which showed the talazoparib level to be increasing to twofold in plasma level compared to when we use talazoparib as a single agent, and because of pharmacokinetic interaction with enzalutamide. So based on that, talazoparib dose is 0.5 milligram, and this was also the dose in the TALAPRO-2 trial, which I will be talking about in a moment, plus enzalutamide. So in this trial, patients are stratified by de novo versus relapse disease, or metachronous versus synchronous disease, as we call them nowadays increasingly, and high versus low volume disease, and then BRCA versus non-BRCA mutation. Primary endpoint is, again, we can see here, radiographic progression-free survival, and multiple key secondary points include overall survival, objective responses, and time to PSA progression. So both these trials are ongoing, and we are really hoping to get results from these trials in hopefully in next 1 or 2 years. And if those are positive, we have some more treatment options for these patients who have HRR gene alterations in the hormone-sensitive setting. So now let's move on to the metastatic castrate-resistant prostate cancer setting. There are 3 trials which have been reported now in this context. Number 1 is PROPEL trial. Here I would like to start with PROPEL trial. It was reported last year in the ASCO GU, exactly 1 year ago, by Dr. Fred Saad and Noel Clark. And in this trial, first-line metastatic CRPC patients were enrolled. Docetaxel was allowed in the metastatic hormone-sensitive setting. However, abiraterone or other novel hormonal therapies were not allowed in the castrate-resistant setting, but they were allowed in the prior sensitive setting as long as they could have stopped it. They stopped it more than 12 months prior to enrollment. So some nuances in the design, differences in the design of these trials, but bottom line is these are all first-line mCRPC studies where patients could not have received any treatment for castrate-resistant disease. And these patients were randomized to abiraterone plus olaparib, 300 milligram twice daily, versus abiraterone plus placebo with continuation of androgen deprivation therapy. The stratification factors were site of metastasis, the bone versus visceral, and prior taxane, yes and no, in the metastatic hormone-sensitive setting. Primary endpoint is radiographic progression-free survival, and secondary endpoint was overall survival. So these were the results which were presented last year in the ASCO GU, and the results showed that the combination of abiraterone plus olaparib significantly improved radiographic progression-free survival in this all-comer population, regardless of homologous recombination repair gene-related mutations, compared to abiraterone alone. And the median radiographic PFS was 24.8 months, in the experimental arm with olaparib and was 16.6 months in abiraterone only arm. And by the way, this trial exactly mimicked the data or rPFS benefit from the earlier phase 2 trial, which was presented about 4 or 5 years ago. I think that trial was called Study 8. It was presented by Dr. Noel Clark and published in Lancet Oncology. So in the bottom line, what is the message here? That these patients who were unselected for HRR alterations, they seem to benefit with the combination of abiraterone plus olaparib versus abiraterone in mCRPC setting. The patients were not prospectively assessed for HRR gene alterations. Retrospective assessment was done, and we can see here, if you look at the look into the box, the radiographic progression-free survival was more pronounced in patients who had HRR mutations versus who do not have HRR mutation. So if you look at the hazard ratio of 0.54 in the HRR positive patients, it was basically 50% reduction in risk of progression or death versus patients who did not have HRR alterations or gene alterations. There was 25% reduction in risk of progression or death. So we did see difference in the level of benefit depending upon the underlying HRR status. If you look at the objective responses, these were confirmed objective responses. They were higher in the abiraterone plus olaparib arm. The final OS data were presented yesterday by Dr. Clark, and this was the late-breaking abstract. And we saw here that although median overall survival in this all-comer population was improved by 7 months in the abiraterone plus olaparib arm, this did not reach the statistically significant level. And hazard ratio was 0.81, favoring abiraterone plus olaparib. And this was a secondary endpoint, and we can see here very clearly there seemed to be a survival benefit, but it did not meet statistical significance. So moving on to the magnitude trial, very similar trial in a way that patients are being randomized to abiraterone plus niraparib, another PARP inhibitor, versus abiraterone. All these patients were in first-line mCRPC setting. Some nuances in the as was a difference as far as trial design is concerned. These patients, some of them were actually these patients were allowed to have received abiraterone for 4 months prior to starting protocol therapy. So as opposed to PROPEL trial, which did not allow any abiraterone or NHT in the castration-sensitive setting, this trial allowed abiraterone for up to 4 months in the castration-resistant setting. Also a big difference, despite the apparent similarities, they were prospectively assessed for the presence or absence of homologous recombination repair gene alterations. And then those are clearly two different cohorts, HRR altered patients versus HRR negative patients, and they were independently randomized to the combination of abiraterone plus niraparib versus abiraterone plus placebo. The HRR negative cohort enrollment was planned for 600 patients, but was halted after 200 patients after investigators assessed no benefit of the combination of abiraterone plus niraparib in this HRR negative patients. And then trial continued accrual in those 400 patients in the HRR biomarker positive patients. Radiographic progression-free survival was the primary endpoint, and we see here that the radiographic progression-free survival was improved in the BRCA1, BRCA2 subgroup, and all patients who were HRR mutation positive. So here we have the values. rPFS was 16.5 months. This was median rPFS in the niraparib plus abiraterone arm, and it was 13.7 months in the abiraterone plus placebo arm, with a 27% reduction in risk of progression or death. If you look at the responses, we can see that responses were improved in the HRR positive patients and more improved in BRCA1 and BRCA2 patients. So BRCA1, BRCA2 positive patients seem to derive more benefit versus other HRR positive patients. So we are not talking about any HRR negative patients here. We are only talking about the patients who were HRR gene mutation positive. And among those patients, BRCA1 and BRCA2 mutated patients seem to be deriving higher level of benefit. And now this is a longer follow-up, which was presented by Dr. Efstathiou in one of the oral presentations yesterday. And here we saw the longer follow-up in BRCA1, BRCA2 patients, so patients who had BRCA1 and BRCA2 mutations. And we can see here that radiographic progression-free survival in the second pre-specified interim analysis continues to show benefit with a combination of abiraterone plus niraparib versus abiraterone with a hazard ratio of 0.55. So almost 50% reduction in risk of progression or death in patients who are BRCA positive. I did not see the report on other HRR mutation positive in this presentation. So let's come to the TALAPRO-2 trial, which I presented yesterday. This was the third trial in this string of 3 trials where these combinations were tested in first-line mCRPC setting. So this was, again, a phase 3 trial, a pre-phase 3 part 1 phase assessed or estimated or basically assessed the dose of talazoparib in combination with enzalutamide. And in that trial, we determined that talazoparib dose should be 0.5 milligram in combination of enzalutamide because the plasma level of talazoparib in presence of enzalutamide rises 2-fold compared to talazoparib monotherapy. So once the dose was determined, this trial moved to the phase 3 portion or randomized portion where patients in first-line mCRPC, they could not have, were randomized to these 2 arms of enzalutamide plus talazoparib versus enzalutamide plus placebo. Patients could not have received any treatment in the castration-resistant setting, and they had to be mildly or asymptomatic. And stratification factors were receipt of novel hormonal therapy in the metastatic hormone-sensitive prostate cancer setting, and whether they were positive for DDR alterations or non-deficient plus unknown. And the reason the unknown patients were clubbed with non-deficient patients in this stratification factor is because at that time when the trial was being conceptualized, it was based on the real-world evidence. We estimated that there will be around 20 to 30% patients who, despite prospective tumor tissue testing, will not be able to have their HRR status determined. And based on that, because if you just look at the real-world prevalence of HRR mutations, 20% are positive, 80% are negative. Based on that, they were put together with HRR negative patients, and this was agreed upon with the regulatory bodies. So just some extra discussion beyond what I discussed yesterday. Primary endpoint was radiographic progression-free survival. Key secondary endpoint was overall survival, and time to PSA progression, time to chemotherapy, and so on, and of course, quality of life. So we can see here the primary endpoint was met in this all-comer population where rPFS was 22 months in the enzalutamide plus placebo arm, and it was not reached in the experimental arm with talazoparib with a hazard ratio of 0.63, 37% reduction in risk of progression or death, and this happened after 2 years of follow-up. Looking at this box, investigator-assessed review was very similar to independent radiology assessment. The hazard ratio by independent radiology was 0.63. It was 0.64 in the investigator-assessed assessment. So pretty consistent benefit. If you look at the benefit by HRR status, so HRR deficient versus HRR non-deficient or unknown, we clearly see higher magnitude of benefit in patients who have homologous recombination repair gene mutations. There was a 54% reduction in risk of progression or death with a hazard ratio of 0.46, favoring enzalutamide plus talazoparib arm. In the HRR negative or unknown status patients, there was a 30% reduction in risk of progression or death. Based on the discussion last year after the PROPEL trial data were presented, we decided to do a exploratory analysis of only those patients who were HRR non-deficient, so they could not, who were not found to have any HRR gene mutation based on prospective tumor tissue testing. So there were close to 400 patients in this group, and when we look at the radiographic progression-free survival benefit, it is clearly present. There was a 34% reduction in risk of progression or death in the talazoparib arm compared to the control arm of enzalutamide plus placebo. So yes, benefit is present in both subsets of positive and negative, but magnitude of the benefit is different. With that, I'd like to take a moment to answer a follow-up question. You will do the, I think we have a CDK thing is still pending, so I'm not sure what the question is.
Okay, I don't think we had any planned questions. Was there additional data that you wanted to present?
Yeah, I'll go ahead and present this.
Yeah, please do.
Yeah, thank you. So let's look at the CDK4 and 6 pathway inhibition in prostate cancer and how this strategy has emerged over the last 3 or 4 years. So we know that CDK4/6 pathway, and I'll make it simple, I won't go through this picture right now. We know that CDK4/6 or cyclin D pathway is relevant in multiple cancers, and in breast cancer there are 3 CDK4/6 inhibitors approved, which include palbociclib, ribociclib, and abemaciclib. Abemaciclib is also approved in the adjuvant therapy in early stage breast cancer. And all these three CDK4/6 inhibitors are approved in metastatic breast cancer. So this is the background. We also know that this pathway has relevance in prostate cancer and metastatic prostate cancer. So this is an ongoing trial in hormone-sensitive setting. So this is called Cyclone 3 trial, where patients with newly diagnosed metastatic prostate cancer are being randomized to ADT plus abiraterone plus placebo versus ADT plus abiraterone plus abemaciclib. There are some key eligibility criteria which I would like to highlight, and that include high risk, and that basically these require patients to have high risk metastatic hormone-sensitive prostate cancer, and risk criteria is more than four or more bone metastasis on the bone scan, and at least 1 visceral metastasis on the CT scan or MRI. So if patient has 4 or more bone metastasis, they are eligible. If the patient has 1 liver metastasis, they are eligible. If they are both, they are still eligible. So they have to meet these high-risk criteria. And stratification factors are de novo versus relapse metastasis, so synchronous versus metachronous metastasis, presence or absence of visceral metastasis, and whether patient received prior docetaxel chemotherapy in the hormone-sensitive setting. Primary objective is radiographic progression-free survival, and key secondary endpoints are radiographic progression-free survival, castration-resistant prostate cancer-free survival, so time to delay in castration-resistant disease, time to pain progression, and time to deterioration in health-related quality of life. So this trial is in progress. Dr. Smith has this trial in progress abstract in this meeting, and we encourage you to refer patients for this trial. In fact, this trial will soon be one of the very few trials which are open in metastatic hormone-sensitive setting. And these patients, trial eligibility criteria are quite relaxed, except that these patients have to meet these high-risk features. So let's go to the castrate-resistant trials with the same combination. So there is a phase 2/3 cyclin 2 trial, and this is a schema of this trial in front of you. This trial was started about 4 years ago, and there was a lead-in phase of 30 patients, where all these patients who had to be in first-line mCRPC setting, so they could not have received any life-prolonging drug for metastatic CRPC setting, in the metastatic CRPC setting, and the dose of abemaciclib was established first in this trial, and then, and as you can see here, then the trial moved on to the randomized portion. And in the randomized portion, the patients first enrolled in the first 150 patient cohort to make sure there was some benefit. And pending benefit, the trial was supposed to move to the larger phase 3 portion. So a lot of stages in one trial. I think this is a very pragmatically designed trial where we are not, where the investigators are not wasting time in designing one protocol and then activating that protocol and moving on to the next protocol. This is basically a continuation of one trial evolving from dose finding strategy to phase 3 portion. So trial has completed accrual, and primary endpoint is radiographic progression-free survival, and we are hoping to see the results in the near future. And if the trial is positive, we'll have one more option for patients who have newly diagnosed metastatic CRPC or castrate-resistant prostate cancer in our clinic. So before I conclude, I again want to highlight the role of Zero. This organization has been very helpful to the patients at facing different challenges with the diagnosis of prostate cancer when they are receiving treatment, when they are not able to afford the co-pays, when they need a multitude of support. This organization is trying very hard to support our patients. So this is the information on this of this organization, which also helps with getting diverse group of patients on clinical trials, which is one of the top priorities by regulatory bodies at present. So please keep in mind that Zero is an organization which is there to support our patients and encourage our patients to seek help from them. Thank you very much.
Thank you, Dr. Agarwal. That was terrific. So in the time we have remaining, we'll try to address some of the questions that have been posed by the in-person and online audience. So Dr. Dorff, if I could ask you a question that we received from the audience is, are there patients with metastatic prostate cancer who do not require intensification? In other words, could be, that you would advise to be treated with ADT alone? And if so, what are the characteristics of such patients?
Metastatic.
Metastatic.
I do have the rare patient who I feel is too frail or has too extensive comorbidities, but they're not very many, to be honest. Even sometimes patients with fairly significant cardiovascular disease, I've gone back and forth with their cardiologist and have felt that it was worth intensifying because not only do they live longer, but there's better control even in the short term, right? So especially if they're symptomatic, I think you have to really try hard to find a reason to not intensify. But for instance, I have a patient who had a recent stroke, and I was very concerned about using the androgen receptor antagonists in that patient. There was some reason, I don't remember exactly why, we felt a little concerned even using the abiraterone. So it's not to say I never use monotherapy, but it's got to be in the single digits percentage-wise of my metastatic patients.
So you very thoughtfully commented on like the patient characteristics, older age, comorbidity, frailty. Are there disease characteristics, like are there features of certain presentations of metastatic disease that would also tend to support ADT alone?
Not that I can think of.
Dr. Agarwal?
Yeah, so no disease characteristic can justify not using intensification anymore, in my view, and I think that is supported by the data. Patient characteristics, of course. So if I estimate the median overall survival of a given patient to be less than 2 years, now of course nobody has a crystal ball, but we all are treating patients in our clinics, and patient have, so anytime I think patient is probably not going to survive beyond 2 years, I have a very high threshold of bringing up intensification. So these patients have congestive heart failure, end-stage diabetes with multiple complications of diabetes, and say stroke. I saw a patient with massive stroke and couldn't really, was not able to be ambulatory, was mostly bedridden. We couldn't justify intensified ADT. But these are less than 3% patients.
No, I appreciate it. So I share your view. We really, the standard of care really now is intensification, and you need to think of reasons, you have to find a good reason not to do that, and certainly need to have that conversation with patients. Kind of a related question we got from the audience is, are there settings for which you would have such a good response? So a patient, say, with metastatic disease, won't specify the details, who has a PSA decline to undetectable on ADT and an AR pathway inhibitor, has side effects of treatment. Are there situations where you would agree to discontinue treatment, or even go so far as to say recommend treatment discontinuation? Dr. Agarwal, you want to take that first?
Yes, of course. So answer is not yet. We have to address this question in a clinical trial. So we often see patients in our clinic who start bicalutamide, then ADT. 2 months after or 6 weeks after doing a routine follow-up, they have a PSA of 0.2 or 1 or 2, down from, say, PS of 800, just a scenario. And patients often ask, doc, why should I start anything else? I'm doing so well. So answer is, I do talk to them about all these intensification strategies, and current standard is all these patients should be receiving intensified ADT. Your question on whether some of these patients can drop one of the components, either intensification part or underlying ADT, castration part. Is there a possibility? Answer is yes. I think there is a potential to do that in best responders, but we need clinical trials to answer that.
And I do think there are, highly selected patients where that could be more attractive, particularly in that we talked about treating the primary and limited sites of metastatic disease in patients who've had radiation to all identified sites of disease. I think it may lend an opportunity to discontinue treatment for those who've achieved a complete PSA response. We also received a question, very humanistic question, is how do you help your patients handle 3 therapies? Do they feel overwhelmed? So I'll take part of that. I think as clinicians, who've been practicing for a long time, we can't help but sort of relate history to patients in describing our treatment recommendations. But I think in some ways you need to get away from that, and I have in my own practice. When we first had evidence for intensification, I would feel compelled to tell a patient, we used to give ADT alone, and now we have evidence to do X, Y, and Z, and so we're going to have that conversation. I think the evidence now is so compelling for addition of an AR pathway inhibitor that when I'm meeting a patient, particularly de novo metastatic disease, I say, we're recommending hormone therapy. For you, that's going to be 2 drugs. It's going to be an injection, it's going to be a pill. You choose your AR pathway inhibitor. And as we get to know each other in coming weeks, we're going to make a decision about whether and when to also add chemotherapy in someone, say, with particularly poor prognosis, de novo metastatic disease. And I think that really makes the conversation easier if you make it seem like they're all options, like it's menu choices. I think it can be quite challenging for patients and overwhelming, because we're not recommending ADT alone. So just make it easy on the patient, tell them they need hormone therapy with 2 drugs. That at least addresses some, I think, the decision-making in terms of how they manage that. I'll maybe ask Dr. Dorff to comment on her experience with triplet therapy.
Well, I just wanted to clarify something you said. So you start the doublet, and then you wait a few weeks to bring in the chemo. Is that...
Yes.
Like, what's your common time frame for when the chemo would start in that scenario?
Yeah, so my reason for starting, particularly with poor prognosis disease, as an example, like high burden de novo metastatic disease, symptomatic, it's just we've decided they're going to get at least a doublet, right? And I prefer to give them a triplet. So just to make that easier, the drugs require insurance preauthorization. They start their ADT, send in a prescription for their AR pathway inhibitor. In the trial, in ARASENS, for example, that's how it was done, and then docetaxel would be started within 6 weeks. I don't feel obligated to do it in that short of a time interval. I'd rather have a little time to get to know the patient and understand how they tolerate ADT and their AR pathway inhibitor alone. If you were to start all 3 literally simultaneously or in very short order, then it can be very hard to disentangle side effects of treatment and what the tolerability issues are. It's a lot for patients to take on emotionally, and medically, so I prefer to space it out longer than 6 weeks. Many of the patients in ARASENS also, would have started their ADT a month or two before they entered the trial. Then we'd add darolutamide or placebo, and then they got chemotherapy. But that had to be within 6 weeks. I'm very comfortable with doing it longer. In the docetaxel trials, that interval was considerably longer from start of ADT.
Yeah, I just wanted to highlight that because I thought that was a very interesting point. I think the other thing I try to do in helping patients with what is so complicated, especially if you're using abiraterone and then there's the prednisone and there's the with food, without food, it's a lot to discuss. And then with docetaxel, there's the pre-medication with dexamethasone the day before the DAT, right? So it does become overwhelming. I sometimes will have my nurse practitioner or my pharmacist come in and spend additional time beyond what I can do with the patient, going through, like, reviewing, educating even more about the treatments. And I try to save some aspects for later, because I tell them we're going to be meeting very often. So things like the genetic testing, things like bone supportive agents are sometimes saved in my clinic for the second or third visit so that it's not so completely overwhelming. I really focus on, like what you said, the backbone of the therapy, introducing them to the possibility of triplet or a trial, and then filling in the rest of my checklist, the bone density and the genetic testing, maybe for another day.
I like that approach, and even the most sophisticated patients, when I meet them, I will tell them the following: is we cannot do this all today. It's not possible, nor should we try. And we're going to get to know each other very well, and you're going to have plenty of time to sort this out. But here's what we need to cover today, and here's the plan for what we'll address in coming visits. You have any pearls of wisdom,
No,
Dr. Agarwal?
Very similar experiences, yeah.
Yeah, what I find remarkable in these forums and others is how we kind of independently arrive at some similar themes in how we manage what I think are very complicated problems. So I think we have time for just a couple of additional questions. Along the same theme with HSPC, some of the other trials that looked at AR pathway inhibitors allowed chemotherapy. They were not specifically designed to address that question, but some of them did it in a different way, which was they got the chemotherapy in and then went on to the AR pathway inhibitor. Dr. Agarwal, do you have a preference of how you do it in that setting?
Just follow the evidence, which has so far shown that there is no role for docetaxel followed by initiation of a AR pathway inhibitor. We saw results from the subgroup. Obviously, they were not powered, but in the ARCHES trial, in the TITAN trial, none of those subsets where patients got docetaxel first, followed by these novel hormonal therapies, they don't seem to be benefiting. On the other hand, we have PEACE-1 trial and ARASENS trial, which show concurrent administration of docetaxel plus novel hormonal therapy to improve survival. So if I do triplet therapy, we do them together.
Okay. Any closing thoughts?
No, I think we've hit on a lot of the complexities of these patients. I think the imaging piece becomes very difficult as we're getting the PSMA PET scans. And, all of these trials used conventional imaging to categorize patients. So although I had a different response to your scenario that you posed, truly we are meant to be basing our decisions on conventional imaging, as hard as that can be. But I would emphasize that some of the most exciting options for patients are going to be clinical trials. You saw a variety of them in the presentations today. We don't want docetaxel to be the only option for a triplet, so we really need to support these other trials that are looking at additional targeted agents in the upfront setting. Because everything we move forward seems to just amplify the benefit, and it will be great if we have different options and not just one type of triplet to offer.
Thank you. Dr. Agarwal, any additional thoughts?
The best treatment for our patients are clinical trials. That's for most of the patients. Thank you.
Yeah, so I really appreciate sharing the stage with the terrific faculty. Thank you, Dr. Dorff. Thank you, Dr. Agarwal. I'd encourage the audience to complete and submit your post-test evaluation for credit. Please download the slides and practice aids, and you're welcome to watch a replay of this event starting sometime tomorrow and in the weeks that follow. Thank you very much for your attention. I wish you a good rest of your evening. Thank you very much.